Good afternoon, everyone. Thanks for joining us today. My name is Marina Terraforte Smith, and I am the program manager of JHM Wiki. If you've joined us before, then you know I'm usually behind the scenes, and that's just how I like it. But today is a special day. Dr. Allison Agwu, our esteemed program director, is actually leading by example yet again. She's currently on Capitol Hill lobbying for several bills to maintain overall HIV funding and promote HIV funding for the HIV workforce, as well as a national PrEP program. So let's take a few seconds and let's harness our good vibes and send them all her way. Because it takes more than just one of me to fill Allison's shoes, I will be joined today by Dr. David Griffith, an expert in pediatric and adult infectious diseases, who needs absolutely no introduction. But for those of you who are joining us for the first time, Dr. Griffith is an assistant professor at the Johns Hopkins University and serves as the medical director of the Johns Hopkins County HIV/AIDS program. He will lead the discussion after our presentation today. He has been featured on this toolkit series every year since our inception, with intriguing topics such as HIV in rural communities just last month, ensuring effective transition from adolescent to adult care, and crucial conversations interrupting perinatal HIV transmissions episode. These episodes and more can be found on our YouTube channel, which I have already posted in the chat. Before introducing you to today's speaker, I just wanted to share a little bit about who we are and why we're here. JHM Wiki is a collaboration between 6 distinguished programs that provide comprehensive care for women, infants, children, and youth, better known as Wiki, including the programs listed here. Our vision is to enhance HIV care coordination and establish interconnected systems that enhance our overall quality of care for HIV. Our mission, how we do plan to achieve that vision, is to collaborate and coordinate across various systems of care to build upon those existing structures. And that's why this platform serves as a signature space for engaging and amplifying you, the experts. If you have any insights to share, or if you know someone who deserves a recognition and should be in this space, please reach out to us. But let us turn our attention today to our featured episode, Optimizing Care for Seniors Living with HIV. Dr. Thomas Laskow is an assistant professor in the Division of Geriatric Medicine and Gerontology here at Johns Hopkins. His clinical focus is on the care of older adults living with HIV, and his research addresses age-related inflammation and the biology of resilient aging. Now, without further ado, let's welcome Dr. Laskow.
Thank you so much, and thank you for the invitation to speak with you all today. So let's try to pull up the slides here. Okay, are you seeing my screen? Yes, okay, great, and the right screen. Okay, so optimizing care for older adults living with HIV. Let's make sure I can advance. All right, so topics for today that I'm gonna, I'm a geriatrician. That's the center of my practice and training. So I'm going to really try to frame our conversation about a classic framework geriatricians use, especially when communicating across disciplines and different providers, which is the 5 M's, and I'll get into that more. We'll also talk about the demographics of aging with HIV and kind of what brings a geriatrician to you all. And although I know many people on this call are very familiar, and I see the names of people who have probably seen versions of what I'll talk about today, but there is some additional information in this talk adapts. Kind of we'll touch a little bit on the biology of aging and how it may connect to HIV, really to help to with a focus on understanding and having concepts to talk about some of the later components, and then we'll really go in more detail into the 5 M's, and for each domain try to add some details or some tools that may be able to affect a person's practice or consider their own health. So I have no disclosures for this talk. And let me set my timer, because I know I'm so glad we're having a question and answer session, but that may lead me to go a little faster in parts. Okay. All right. So the 5Ms framework, you'll see 4Ms. That's kind of like a prior concept, and then Mary Tinetti and group made it the 5Ms for this multi-complexity domain. So, there's a lot of, and all medicine has nuances and complexity, but I do find that focusing on these major buckets of areas that geriatricians and folks who work with older adults and individual people who are aging commonly encounter is helpful. So, one domain is the mind. That includes mood, that includes delirium if you're in the hospital, and of course it includes dementia, which is a major area of concern for many people. Mobility, how does one get around? What is life space? This can change with age or with major illness. Medications, we'll talk about that in detail, but certainly a common trend for anyone who's aging is the tendency to be on more medications with time, and that presents its own challenges. Multi-complexity, this is a big terminology that covers a lot of those areas that don't fit neatly into the other sections, but another aspect of living longer is the potential to have multiple health conditions that interact. As you have issues with mind or mobility, social support and connections around you can matter even more. And so that's psychosocial complexity. And so this is that domain. And then finally, the matters most domain, which is about making sure that we know what is important to a particular older adult and are aligning care and handling the complexity, the medications, and so forth, handling that complexity in a way that aligns with what matters to the individual person. And I'm going to be talking about this today from the perspective of a physician, but it's really important to know that the strength of this approach, and if you're thinking about this in a particular clinical setting or community setting, that geriatrics is always founded on a multidisciplinary mentality, and to address these effectively for individual older adults, it really does take a team and thinking about who can help and support which activities to get this done for an individual person. So celebrating success, this is a common part of my talk, but I think it's always worth highlighting that there have certainly been times in the course of the HIV and the AIDS crisis where we were not thinking about geriatrics, but thanks to the work of members in the community, providers, patients advocating for themselves, this has dramatically changed. There's no graph, and there have been more updates even from the same research group who presented this paper talking about the successes in expanding life expectancy for people who are living with HIV. The main point to take away from this graph is that the lower green and purple bars are kind of anybody who has 3-year follow-up data, including people who had a major health condition or passed away. And then the upper lines, the blue and the red, are for people who survived into their 2nd and 3rd year after, because there's a peril, and when an individual is first accessing treatment and getting treated, depending on where they are. So the overall trend for all these lines, though, over the course of this period of study is going up, and that life expectancy, particularly for men and women who survive into those later years of follow-up, approaching general life expectancy for the overall population, but not there totally. And so there are many aspects of assuring that we close that gap, but also taking the opportunity to celebrate what's been accomplished. And also, no news to many people on this call, but when I talk to other providers, including geriatricians, I often find myself providing education on this, which is that, now in the United States, looking at the median age of a person who is living with HIV, it's, over 50, which is the classical definition in the world of HIV literature for an older person living with HIV. So, these concepts and the approaches of geriatrics, it's definitely high time, that we are incorporating these approaches into care. Along with successes, which are very real and to be affirmed, it's also important to know about the challenges or the things that we, need to support and address as folks grow older with HIV. This is one study. I believe this is the Netherlands cohort that's presented here, where kind of looking at multimorbidity, so having multiple other health conditions with age among people living with HIV, and you can see this is one cohort, but you can see this impression that if you're looking at people who living with HIV or not, there's a trend here where folks at any given age group are experiencing more of this comorbidity, other health conditions that they're facing. And, that's the Netherlands, but they've also looked at Italy and in the United States, and you can see in the United States, even more prominence of people having 3 or more of these comorbid conditions. So, this is the type of complexity that geriatrics has been thinking about for a long time. So those are the challenges. That's the kind of demographics of where we are. And then I'm going to touch on briefly on some concepts from aging biology and how this may connect to HIV. And really, this is not meant to be like a science-y talk. It's more of a way of kind of getting everybody on the same page. And there are a couple concepts here that come up in later discussion. So, one framing of the importance of aging and geriatrics to HIV is this idea of accelerated aging in HIV, which is that there are, some health conditions, diabetes, heart disease, kidney disease, osteoporosis, where are conditions that people encounter with aging, and individuals living with HIV can encounter them at an earlier age. People on this call are very familiar that some of that is maybe HIV, some of that, pretty good evidence is connected to medications that are ever getting more refined. But the net idea is, should we be thinking about this as relating to aging biology? And aging biology, whole other domain, and this paper has since been updated, but it works for here, which is, we think that as people age, there are multiple even though we have multiple different health conditions, there's some underlying drivers at the level of our, DNA repair, of our mitochondria, those are the little powerhouses inside of the cell, and other telomeres, the ends of our DNA that get shorter as it replicates, that may be contributing to the things we see in aging, why people have more heart disease, why people have a elevated cancer risk, why people develop osteoporosis. Are there some underlying drivers there? And the idea is, as this figure captures with slightly different hallmarks, but basically that the idea in that aging biology picture is that you have these underlying molecular processes that are happening inside of the cells of our body as we age, and that then that kind of emerges with time into chronic conditions that we see with aging, everything from arthritis to chronic kidney disease and more. So, when someone says, and when you read or are participating in discussion where the topic is, is HIV, accelerated aging phenotype, people are kind of communicating an idea, and it's good to be, familiar with this idea for your own thinking about it, that is it the case that the HIV viral exposure or antiretroviral therapy itself is feeding into these same pathways that influence aging and age-related diseases, and then causing people to develop these conditions at an earlier age. And a lot of research has gone into this to date. And so, this is just one way to summarize for both the hallmarks that are in that prior paper and the hallmarks that are not in that paper, some other conditions that happen with aging. The red boxes are around domains in which there's been prior research suggesting that that pathway that's aging associated is also perturbed or affected in individuals who are living with HIV. So inflammation, telomeres, mitochondria, some of the domains we already talked about, these all are places where, someone has done research and suggested that this is a common pathway affected in both conditions. And then the concept that I just want to hit on here, I don't have any kind of final answers, and the truth of the matter is probably that, a bit of both, or it depends on the condition, but is the idea of, what do we mean specifically? This is a nice figure, and there's the link to the educational materials below, but, two concepts. One is accelerated aging, where a person who's living with HIV is at risk for developing a particular condition at an earlier age. And another is accentuated aging, where at any given age, people are developing the condition, but it's just more there's a higher frequency, higher incidence at any given age of people developing that condition. And so you could also imagine a situation where people have both of these processes going on. And the data to date that I am familiar with is that we probably see slightly different processes going on in different conditions. So, good examples here is for bone fractures, kind of an osteoporosis surrogate. Maybe this is accentuated aging, just at any given age. A person who's living with HIV has an increased risk for that. And then for diabetes, perhaps this is another accentuated aging. And then for kidney failure, as the example here, perhaps this is a situation where we're seeing some component of acceleration, so happening at an earlier age, as well as that accentuation of the probability. And, why does this matter? I mean, partly because people talk about this, and when they're reporting, I'll talk a little bit about cognition and aging with HIV, and these concepts of, is this acceleration, is this accentuated, are ways that people try to communicate and understand what may be happening as people age. But then, basically some of this is, comes down to, is HIV and the medications we use to effectively treat HIV another chronic condition, or is there something intrinsically related to these aging pathways to understand? And if it's mediated, if things are happening because of these aging pathways, maybe we use an intervention designed to target these aging pathways to help older adults live better with HIV. And if it's one of many other comorbid conditions or other things going on with someone's life, maybe HIV is just one more factor, and all the standard things we do to support an individual's healthcare and modify risk is where the focus needs to be. And, punchline for me is that it's probably both. We should look for these aging-related pathways that may help people, but the immediate thing we can do now is to modify risk factors. So coming back to the 5 M's, I'm going to go through these pretty much one by one and try to help you all think about ways that these tools can translate into the care for someone who's living with HIV as they age. So matters most, these are the overall high-level things. So just if people haven't thought about this before, it's both like literally a person's goals and what's important to them, and also kind of how goals interact with the health system, as in goals of care planning and saying what you'd want if you were sick or unable to speak for yourself. I find that and it's been advised to me, and I really have taken this advice and found it incredibly useful, that 2 really valuable questions in general for probably anyone who's aging, but particularly in the context of someone who's living with HIV is, what does aging mean to you and what matters most to you? So what does aging mean to me? I mean, again, people are different. Anybody could have a different perspective, but certainly someone who lived through the AIDS crisis and saw, friends and people they care for not surviving, and then surviving themselves. People can just have a radically different perspective. It's not really a time to just assume that you can come in with a, birthday candle that says 70 and assume that someone's going to just feel completely happy about that. People feel guilt. People feel just a whole range of emotions, in addition to the many people who are extremely happy to, just celebrate and affirm what's going on. So what does it mean to someone, and understanding a perspective on aging, understanding someone's, feelings of ageism or feelings of lack of worth related to aging, which can happen to anybody. It's really important to know. And then what matters most is really a defining question, because a theme as we go through this talk, is complexity, is more medications, more health conditions, multiple different guidelines, that if all followed to their maximum could make life rather unlivable. And so how do you deal with complexity, when there's never going to be a study that tells us what to do in each highly complex situation? Really, that question of what matters to a person, what's important to them, is, the best guide that from a geriatrician's perspective we have to try to whittle down the complexity and prioritize treatments. An area of this that is kind of practicalities for thinking about matters most in clinical practice beyond those individual questions. One is resources for advanced care planning. This can be a daunting topic for anybody, especially anybody who's had an episode of critical illness and been in the hospital, and it can be scary to think about that. So I always recommend the prepareforyourcare.org. This is a nonprofit website that can generate advanced care directives and has educational videos related to advanced care planning. The directives that you can download are highly readable in simple language and individualized to the state that a person lives in. And that can be a really good starting point for and a good resource for having some of those conversations. Another whole domain here, when thinking about goals of care, is actually, overall health status and prognosis. So this is a very issue that can raise a lot of different perspectives and discussion and fears, which is that, okay, so e-prognosis is a resource for trying to understand someone's likely life expectancy. Okay, how likely is an individual person to live for 2 more years? It's really important to say that none of these prognoses are, accurate enough that I think that they really tell you how any individual person is going to do. It's just kind of a summary statistic. And secondly, even if they were that accurate, that doesn't say what, the correct action is, because that really depends on the person's goals and values. But, in terms of how a geriatrician thinks through and helps to give people good advice, part of it is understanding, these likelihoods in terms of if you're thinking about, what is the goal for someone's hemoglobin A1C? What is the goal for someone's, should this individual person be on a statin? Based on, kind of general recommendations before you start tailoring to the person's values. This type of prognostic information helps to make that type of advice in a more consistent way that doesn't just involve my individual bias based on what my impression. It makes me ask the same questions for everybody and compare. And then the VAX 2.0 score, that's the a score from the Veterans Affairs group, and that's basically a calculator that takes laboratory values that's specific to folks who are living with HIV, and it kind of can help, again, to get an estimate of what is someone's 5-year survival. So I don't think that, again, that doesn't speak to any individual person's survival. That's not the be-all and end-all, but it is an example of a way of bringing into the realm of thought, how sick is this person? What are their risks? So that can be included in the conversation in a thoughtful way, not coming into the room and saying, well, you have a 10% chance, you have a 10% chance of dying in this period of time. No, that's not the appropriate way to use that resource. So Mind, I see a comment in the chat here. Oh, great. Thank you so much for including that link. So we're going to talk about Mind now. And some of this is more, individual considerations in the context of HIV, and we'll go into this in some detail. So these are the general areas that we put in this realm for geriatrics. Delirium is not that's like kind of a short-term confusion that someone may experience in the hospital if they're very sick at home. And so we're not going to talk about that very much today, but we will talk about these other domains. And here's kind of how we'll walk through it with the terms and the goals of the evaluation and screening and what kind of geriatricians think about beyond that. So again, I know many people may be familiar with this, but I think it's useful to make sure we have the same terms. So there's a whole set of experiences and conditions individuals face and research related to that on HIV-associated neurocognitive disorders, or HAND. And then there's a spectrum of severity of those types of situations that individuals can face. So along that spectrum, asymptomatic neurocognitive impairment, this is if you do a psych testing or a neurocognitive battery, you can detect that some degree of impairment, but a person isn't functioning, they're not noticing it, and they're not having any personal issues. Then there's the mild neurocognitive disorder domain, or MND, and this is for individuals, and this is extremely common for folks living with HIV, is, okay, you're having some day-to-day issues with memory, issues with focus or attention, and you notice it, and you're having, that can be seen on a neurocognitive assessment, but you're functioning, pretty well. You're doing everything you need to do, paying your bills, able to do a job, do whatever it is that you need to do day to day, but you do notice something. And then HIV-associated dementias, where you're having cognitive impairment and you're also having the functional impairments that are affecting your ability to do your activities of daily living and get things done that you need to do to live independently and conduct your activities. So, the biggest takeaway message I have for this, to understand this, is just to see that before and after antiretroviral therapy came onto the scene, and the trend that has happened is that we still have a lot of people who experience some neurocognitive differences that are associated with HIV, but that the prevalence of the actual dementia associated with HIV is dramatically lower. Not zero, but much lower in the context of antiretroviral therapy. And so when someone comes to, be assessed, whether it's by a geriatrician, if it's kind of a chronic process, or if there's some acute change, or someone's seeing a neurologist, then in that setting, one of the big tasks is trying to understand, is this HIV-associated neurocognitive disorder, or is this any of the other age-associated neurodegenerative diseases that anybody who's aging has the potential to experience, or some overlying combination of these two conditions. And so a question that I'm commonly asked, probably one of the questions I'm most commonly asked, is about the relationship between HIV and neurocognitive aging. So, between those two domains that I was saying that we try to look at. So how does HIV and the known neurocognitive experience of having some challenges there affect aging, and does it make you, at risk for Alzheimer's, and these types of questions? And this is a study from 2021. There's additional literature that has emerged since this time, but this was a big attempt at a full systematic review and meta-analysis. They weren't able to do a meta-analysis because of the difference in the study designs, but the takeaway that I would take from all of this is that, what we know for sure is that many people, whether they're younger or older, experience some neurocognitive symptoms related to aging. And there's a signal, it depends on the specific part of cognition and memory that you're testing, and that can change between studies. But there's some signal that people, as they're aging with HIV, may, be at risk for more or more rapid, some aspect of cognition, but that is not overwhelming data, and that we don't, know for sure. And certainly, I would say that I would take some, if you're an individual person who's aging with HIV, I would take some hope from that. We need more information. We need to understand neurocognitive aging in HIV better. And it's an ongoing area of research. But whatever is going on is not so dramatic fundamentally that it's, like people feel like they're locked into some type of accelerating neurocognitive disorder with aging. And so, practically, what can we do here? So it's a lot of it is screening and support. At this point, if someone does have a, diagnosed dementia, whether it's Alzheimer's or so on, then there may be a role, there's a recommendation for a role for anticholinergic so cholinesterase inhibitors to support people in their cognition, at least a trial of that. And so what can we do and when do we screen? So this is variable, and I think I have a responsibility to tell you all about where there's, consensus, what is the evidence, what do we have guidelines on. So the U.S. Preventative Services Task Force does not recommend in all population that we do general screening. I think that there's times when it's very strong to screen, and where I don't think there's any debate is if a person or a family member is reporting symptoms, if a clinician has concern, or, for me as a geriatrician, this is a domain that I commonly assess. And so I am a person who, would always do at least some degree of assessment as part of my initial exam anyways. And so, there's the more in-depth battery that I more commonly use is the Montreal Cognitive Assessment, or the MoCA. And there's a fairly good literature in the context of HIV as well to support that. And that's nice because it has the overlap. It's not specific to HIV related cognitive impairment, but it's also covers some similar domains. And so that's what I typically use for more in-depth. And then if memory is not a major concern of anyone at the visit, I'll sometimes use the mini cog, which is a shorter assessment that asks people to do a 3-word recall and to do a clock face drawing assessment. And if that isn't pretty normal, the chances of someone having dementia is significantly lower. And so that can be an initial screening. And so these are some reasons why I use it. It's also very important to know that, other aspects of mood and emotion and psychiatric well-being can also play into cognitive symptoms. The most classic one for that is depression. And so it's always important, if you're thinking about cognitive screening, to also look at a depression screening, whether with the PHQ-9 or the Geriatric Depression Scale, which is one of the validated scales specifically for older adults in whom depression can manifest a little bit differently. And then also paying attention to these ADLs and IADLs, because that's really where we have the call on understanding, is this mild or cognitive impairment, or is this, dementia? That's where we really make that distinction. And the things to support, in addition to particular treatments, this kind of all the above approach, there really are things that we can do to reduce our risk with diet, exercise, managing substance use, including tobacco, care planning, figuring out what support someone has, optimizing vision and hearing. Hearing is thought to be one of the most is one of the major modifiable risk factors for developing dementia. Not if you're born with a hearing impairment, but if you're a person who develops that in the context of aging. And so, making sure that hearing is addressed, and if people need hearing aids, to get them is an important part of the picture. And so then we'll talk, just kind of backing up a little bit. So that's all about cognition, but it's important to remember and bring back this theme of multi-complexity, that, say someone has mild cognitive impairment, or in the context of HIV, mild neurocognitive disorder, that's not kind of like stopping there in terms of one's curiosity for understanding a situation and age-associated risk factors. And at least one prior study looking at a particular clinical center, they found that having that MND was associated with also a range of other age-associated conditions, from falls to frailty to difficulty in ADLs to urinary incontinence. And so it's really an opportunity to be curious and understanding what other age-associated conditions someone may be experiencing and to ask more. So for mobility, I'm going to keep this one brief, which is that there's not an increased risk per se in studies, literature that I'm aware of falls for folks who are living with HIV versus not as they age. And that being said, people will have fall risk and will need assessment. So, have you fallen in the past year is a great screening question. And then if you're trying to do a gait assessment in the office, I really do recommend the timed up and go test, which you can look up online. It's basically what it sounds like. You're having someone stand from a chair, walk a fixed distance to you, and then turn back well timed at their normal speed. And that is a useful screening test as well. And then, there are general resources for many aspects of aging and aging with in a healthful way that is available at the National Institute on Aging website. But here's just one of their info sheets on steps to take to reduce fall risk. Medications. So I'll talk a little bit about some considerations of HIV and antiretroviral therapy specific aspects. I, as a kind of a consulting geriatrician, I'm not initiating individuals on their HIV regimens, and I'm rarely, commenting on a time to change them. So, there may be providers who are doing that every day on the call, and I welcome your thoughts. I'm just going to share some general pieces of information or things to consider in the aging context, and then we'll talk a little bit about deprescribing and polypharmacy. So when should someone initiate antiretroviral therapy for older adults? I mean, we know the recommendations to initiate therapy for everyone. Just an interesting thing is that older adults may even get more benefit from an early initiation than younger folks. So an important point. The regimens that are recommended to start on are the same for older adults as for younger adults, with this added consideration of polypharmacy and comorbidity, which are higher in older adults. What does the pattern look like for someone who's older after initiating antiretroviral therapy? So viral suppression tends to be better, and that could be related to any number of factors and what's going on in someone's life as they age. But that the CD4 count response is often a little less robust in people who are older than 50. In terms of kind of really just basic things that many providers look at and are aware of, but touch on this interaction between aging, polypharmacy, comorbidities, and antiretroviral therapy. So for the integrase inhibitors, antacids, and supplement, and some of these mineral supplements can affect absorption. For the nucleoside reverse transcriptase inhibitors, just keeping in mind that TDF, the prior formulation of tenofovir, has those interactions with renal and bone disease that are non-trivial, and so TAF is the a special consideration in that context, and then of course cardiac risk and bacavir, and then for the non-nucleoside reverse transcriptase inhibitors, just keeping in mind all these interactions with the CYP 450 system. That's your liver's system for cleaning and metabolizing medications. And so statins and some antiplatelet medications, it's important to know that can be affected. And then for the protease inhibitors, The medications that we use to boost or maintain those drugs can also affect the levels for the same reasons of various different other compounds. And then particularly with oral anticoagulants, so if someone has atrial fibrillation, has a history of a clot in the leg or the lungs, and is on chronic medication, this is an area where to make sure that you've carefully checked what the interactions are. And so other age-specific concerns is that, combination pills are fantastic for reducing pill burden, but sometimes those pills then get larger and can be harder to swallow. And so having some curiosity about that, or listening for people talking about issues there. And then also, if this gets complicated, and it can with multimorbidity and polypharmacy, to involve a pharmacist, and there's evidence that that can help with adherence and other things. So to have a low threshold, if you're wondering, to get a pharmacist involved. So I think I've mentioned the word polypharmacy before, but I'll just say, what is that? The rule of thumb, there's no single definition. You can find a million definitions, but 5 or more medications is a common criteria for invoking polypharmacy. And, when people tried to look at the literature in the HIV context, you could define it different ways, but kind of including all of your medications that are for antiretroviral therapy or not, which makes sense because they all would interact with each other regardless of the indication, or have a potential for interaction. That's the criteria. And then, of course, though, when you say that, that's not, means that every single person needs to be on 4 medications. It means that you need to think carefully about, are these medications aligning with a person's goals? Are the risks and benefits aligned? You've looked at drug-drug interactions. If the medication list is getting long, especially, always ideally, but then also the prescribing cascade to be aware of. So is some medication on this list treating a side effect of another medication? And sometimes that's, unavoidable. If someone is in a palliative setting and they're receiving an opiate medication, they need to be on medication to address constipation, and that's appropriate. But, on the other hand, if someone is on a dose of metformin and is experiencing diarrhea, and then is on another medicine, to slow gut motility, then that would be a time to raise questions if that's not aligned with their goals. So being on an appropriate medication and being on more than 5 or more can be perfectly appropriate. It's just something to be aware of. And there's a lot of different literature. There's literature in the US context. This is from a Swiss study of different clinics. I imagine that the incidence of polypharmacy would be even higher in the United States context. But you can see that as people age, unsurprisingly, the number of people on 5 or more medications gradually increases. And so how do we address this? There are different tools. One thing I like is just basically to select a systematic approach. So, and often a pharmacist can be a great help in this. So I have liked the stop-start criteria. They just recently updated these, and in the supplemental materials, you can find the actual list. This is a way of going through and not only looking for medications that a person might not need to be on, that they're on, but also looking at medications they might benefit from that they're not currently prescribed. And so that is a resource that I definitely recommend. And just with any of these, one caution I'd give with any of these deprescribing resources is that they update them at intervals, but then, medical science can change, or there could be new studies and data in the meantime. So these are never a replacement for a clinically trained person's, provider's, judgment and knowledge about what is known, and it always needs to be cross-checked in that way. It's not a check the box type of an exercise. And then also, I'd always point people towards the American Geriatric Society Beers criteria. These are medicines that are known to have more risks and complications in older adults, and these have also recently been updated. Multi-complexity here. So, again, this is health conditions and biopsychosocial situations. So neighborhood, family, housing, everything gets captured in there. And I would, you could find lots of different figures, and this does not just apply to older adults, but, making sure to take this broad approach. If someone's losing weight, there are many medical conditions, but also understanding access to food and financial precarity there is important. And so, I would come back to this idea of what matters most as being a major issue, and then also, understanding that some studies suggest that there's a greater incidence of social isolation in older adults who are living with HIV, and among any older adult, being aware of the risk for substance use is another factor and contributor to polypharmacy as well, of things that can, affect life and need to be asked about and addressed. Other domains for the multi-complexity and aging, I would say that, some common things that we see when I see individual for a referral in a consult setting is thinking about bone health. There can be so many other priorities in a person's care that doing that osteoporosis screening, is a really important step for older people living with HIV, and a DEXA scan to assess that. And then also asking about and treating urinary incontinence, another issue that affects people day to day, affects when people take their medications, affects costs related to products like protective briefs for incontinence, and understanding that there are behavioral interventions to help with urinary incontinence, and also medical therapies, some of which are worse for other aspects of age-related health. Some are better, but at least knowing what the problem is and trying to develop a plan is important. Cardiovascular risk factors, primary care providers for folks who are living with HIV have, really guided the way in terms of making sure we're adequately addressing cardiovascular risk factors to close the gap of differences in expected and life expectancy. But that being said, it's always important to know that the conventional risk calculators don't factor in HIV as a condition, even though we know that it can affect cardiovascular risk. So just making sure that people are screened and on appropriate treatment. And then, and also, on that one, to say that that's another area where, as someone's health is changing, if someone is experiencing increased frailty, pill burden, has had major other medical reversals related to function, and just, that's not a priority, then it may be that you don't need to manage cardiovascular risk factors as intensively. But I would say that in general, for most folks who are aging with HIV, the more common thing is just making sure you're appropriately treating. And then on the other side, with diabetes, type 2 diabetes, this is one where I think a little bit the other way, which is that, there's kind of a mixed message where, again, the way that we're helping to support general health as people age with HIV is to appropriately treat conditions with guideline-directed recommendations, including hemoglobin A1C goals. But something that is important to know about the ADA, the American Diabetes Association guidelines for what a person's A1C goals are, is that they do depend on a clinical context and critically health status. So if someone's dealing with, multimorbidity, loss of function, and, not knowing what that individual's life expectancy will be, but knowing general trends, it is appropriate to bring into a conversation and be aware, is the intensity of this treatment regimen for diabetes really match what someone's goals are? Because, whether that goal is 6.5 or that goal is 8, which can be the goal in the setting of, multi-complexity and other health complications, can really make a difference in terms of, can be a place to intervene or address and kind of de-escalate a little bit to give appropriate care to someone in a shared decision-making model. So that just brings up the last point, that everything that I've said here today, every way that we deal with the complexity of aging really does need to involve this component of shared decision-making. I mean, that's a no, we know that from other aspects of care. I guess where it comes up is that because we're choosing which guidelines to follow, because we're understanding when to continue the plan as it's been for 10 years or when to make a change, and when there's often not the kind of clear-cut research that makes it a home run for knowing what to do for this individual person, it becomes all the more important to use the general good practice medical technique of shared decision making to make sure folks understand the risks and benefits, and that confirming that what we're doing right now in care matches someone's goals. For more details on guidelines and screening recommendations in general, most of them are this, I would say just going to these links and other guidelines to nonprofit resources to, get data. Some of this is, building on that theme of shared decision making. Some of these guidelines are expert opinion rather than, having one good study that tells us exactly what to do when aging with HIV. But, having a touchstone, having a common language or a set of expectations is a good starting point to make sure we're addressing gaps in care and making sure people get, similar consistent care options. So that's, I think, all I have. Just thank you to the Bartlett Clinic for their support in having a geriatrician embedded with them for consultative services. And with that, I think we can transition to a discussion.
David?
Yeah, hi. Sorry, I was talking while muted. Dr. Laskow, thank you so much for this wonderful review. And I liked how you framed it, because I take care of a lot of patients who have perinatally acquired HIV, so now are in their maybe 30s, but have acquired a lot of comorbidities along the way. And so this information, I feel, is even helpful for those folks who do have an accelerated aging because of their kind of exposure to HIV at a young age. So I think it's not only appropriate for older adults, but kind of all of these patients who are dealing with HIV and complex cases. But what I'd like your help with most is your discussion of the neurocognitive issues, I feel like was really helpful. But I struggle when I have a patient who I've identified, I see them and clearly there's some sort of decline, whether it's mild or transition to the dementia stage, and you do your screening to identify it. I struggle a bit with them. What next? You mentioned kind of social isolation. Some of our patients don't have a family member that they're living with. I'm reminded of a patient who, after his husband died suddenly, that's when a lot of these kind of neurocognitive issues came to the forefront for me, because I think the husband was helping him. And so now you have someone who's living on their own and clearly struggling. Are there community resources, or how do we best support individuals and keep them safe once we've identified this issue?
Yeah. So thank you. That is an excellent question. First, the question of, what is aging with HIV, and when you've, perinatally transmission and these things, like, absolutely, that's an area. And that's often, I haven't worked with, or, my referrals are for 50 and older. So I tend to focus on that area just out of the domain of what I have. But, talking to people in the community, I've gotten feedback that that's an area that I, don't address. But I guess the lowest hanging fruit would just be to encourage, definitely, if there's anything in this talk, and I'm sure there is, that resonates, I think that it's totally appropriate to work with that. And I'm so glad for that cross discussion in terms of nuts and bolts of what to do. So there is the Baltimore, the Department of Aging, and they have some resources in the community, and they, their contact information, I can pull it up online and try to, if someone is faster than me, then we can do this, but I just want to make sure that we get this out there. So let me get that contact. Aging Services within the Baltimore City Department of Health. So,
And would other counties have a similar office that would have those resources?
oh, that's good. So I think that, in there's not, I don't know that they all do have it, but I think that at the overall level of like Maryland, there are also some resources. Let me see if I should have had these on hand. These are anticipated questions. Okay, so where is my chat thing? So, okay, so this is the Baltimore City program. And then there are some good resources at the state level. Let me just, Maryland Department on Aging. So, yeah, we actually just had the Maryland Secretary, I believe her title is Secretary on Aging, come and speak at Johns Hopkins Bayview. So this is a starting point, at least for resources, and it's a pretty good website. Okay. So yeah, so these are some places to start. There's also just the Alzheimer's Association. They have a hotline number that can be called, and that is not specific to Alzheimer's disease. So that's another way that people can kind of rapidly try, or family, we're talking about social isolation here as well as a component. And so, an individual who's dealing with mild dementia may have variable, ability or bandwidth to do this, but is another, but generally is a place that I'll refer people to as well. And there's a hotline component of that that's, connected to the idea of resources that are available to people. So that's one level. Another level is depending on someone's, there's a whole issue of if someone is truly experiencing, and this absolutely happens, someone is experiencing dementia, and it is affecting them to a way in which is affecting their capacity to make decisions. And that is a person who's experienced, is experiencing social isolation, and then how to address that. And that kind of, goes down to the root of guardianship discussions. And that's would be in Baltimore City, a discussion with the Department of Health. And but in other counties, I imagine there's a similar process for addressing that. That's where we don't want to get to. And so we, kind of an early phase of this that I'm sure that many people are familiar with here is, sharing with and talking about advanced care planning and, identifying someone who's an advocate to speak for someone from their corner. And that being potentially a challenging activity for someone to identify if they're experiencing social isolation, if they're experiencing stigma, from family. This can often get complicated, but I guess the greatest hope we have, I suppose, is to start that conversation early and to be talking about it, earlier than we all do, in the hopes that someone can come up with somebody who they, feel like knows them well enough to help with those choices.
Yeah, that's
a
great reminder to have those conversations earlier than we do.
Yeah, it doesn't help with the immediate situation. And often we have that conversation visit to visit and we don't, frankly, find that person, but that's the best outcome.
There was a question in the chat about kind of specifically about women living with HIV and discussions around menopause and post-menopause management. Jackie, you can speak up, or I don't know if Dr. Laskow, if you have any specific recommendations there.
Yeah, I don't think, I think that that's an excellent topic. And I would say that overall management considerations for me are, similar. I don't think that there's enough that women who are experiencing menopause and postmenopausal, perimenopausal symptoms, that's very affecting of life, or depends on the individual person. And so I don't think that there's anything about living with HIV that would, preclude you from, exploring the existing options. So, yeah.
All right. It looks like we are at time. I think I didn't see any other questions in the chat, but Marianus, I'll leave it to you to wrap up.
Oh, there we go. Thank you everyone for joining us today. We really appreciate your time, and the video will be posted to YouTube tomorrow. Hope you guys have a great weekend and take care of yourself. See you next month.
Thank you again for having me. Nice to
Thank
talk
you.
to you all.
Thank you, Dr. Laskow. Thank you, David.